We're going to cover heart, lung, and abdomen examinations in this lecture. With a thorax, we're going to want to make sure that we can actually visualize this area. So you're going to want to make sure that if your patient has a gown on or a shirt, that you're able to visualize their thorax area. You're going to want to look for the symmetry of the chest. You're going to want to look at how the female is developing. What you might see in a newborn female is that they actually develop some breast buds. And this isn't anything to be concerned about. It's fairly normal. It happens as mom's hormones get passed on to babies. So you may see some breast buds early in those babies. Other things to note in our newborns is the clavicles. The clavicle is the most commonly fractured bone during the delivery process, and sometimes this can actually get overlooked. So you want to make sure that you visualize the area and make sure there's no asymmetries on either side or any bumps. You may also want to palpate along there to see if you feel any abnormalities as well. I want to go over Tanner staging. As chiropractors, this isn't something that we often do a lot of, but I wanted you to be aware of the term, as in the past it has been on some of your sports pre-participation physicals. I know it used to be on Missouri's years ago. I don't think it is any longer, but I do want you to know what this term is. As we're evaluating patients and adolescents, understanding where they are at in sexual maturity is an important thing as well. And so one of the things that this Tanner staging does is that it actually measures the level of sexual maturity in different organs. So it looks at pubic hair development, genitalia, and to see where they're at now. So this isn't a common thing that chiropractors will do, but I do want you to be aware of what this is in case you come across Tanner staging at some point. So you can see that stage 1 would be what our children would be at the level of versus level 5 or stage 5, which would be adult level. When we're thinking about possible lung and heart issues that come in the pediatric populations, there are a few other questions that you may want to go over with the parent. If you do suspect there be some kind of issue with this area, some questions that you might want to consider is how does the infant feed? If they're nursing with a breast milk or being formula fed with a bottle. I mean, both of these methods can show some difficulty. So, when they are eating, are they out of breath? Are they sweating maybe when they shouldn't, especially while they're feeding? Are you noticing that the baby is breathing really quickly even when they're at rest? Have you seen a change in their growth pattern? Sometimes growth development, whether that be it's slow or too high, can actually show some issues with heart and lung. Are they getting tired really easily? So we want to make sure that if we do suspect an issue or we're starting to see some signs either in their history or in their evaluation, that we maybe ask a few follow-up questions with that. As far as our lung and heart exam go in the pediatric population, I don't really have a lot of pediatric specific things to go over with you. So a lot of this is going to be a review of what you already know with the adult examination. But we're going to start with inspecting the thorax. So we're going to, again, kind of look for symmetry. We're going to look at color. We're going to look to see how they're breathing, if we're showing any of that extra effort. Are they chest breathers? Are they abdomen breathers? We want to make sure that we're noting that. So like I said earlier on in the vital section, infants and small children are mostly abdominal breathers. As they get into older child, adolescent, you're going to see that move more chest or costal breathing with that. We're going to palpate. So the biggest way I palpate is I just put my hands kind of on their back and feel for any kind of vibration or fremitus as they breathe in and out. That may show some issues with breathing if you do feel that vibration. Maybe part of maybe they're having an upper respiratory cold or some other kind of respiratory infection that's showing some of those findings. So just as far as palpation goes, I just put my hands over their lung fields on their back and feel for any vibration with that. Percussing the lung fields, this is part of the lung examination, so we'll want to make sure that we're percussing in the regular pattern that we're used to. We're going to auscultate the lung fields. With this one, sometimes it's hard to get the child to follow directions, and so to get the kid to take a deep breath, you may have them pretend to blow out birthday candles or pretend to blow out your otoscope light. That might be an easy trick to get the child to take a nice deep breath in and let it out as you're listening to their lung fields. Remember, with the rate of their respiration, we already talked about this in the vital section, but we're going to look at their chest or belly rising to help count that, or you can put the stethoscope underneath their nose to help you with the rate of that. This is, again, another one of those physical exam procedures that may need to be done early on in your examination or while the infant or child is nice and calm and maybe even sleeping during your visit. And lastly, another thing that you can do is measure the chest circumference. So if you think that the child is having some issues with breathing or there's some abnormalities in their chest, you can also measure their chest circumference at their nipple line. And one of the interesting facts I've got for you is that their chest circumference is actually the same as their head circumference, and from age 6 months to 2 years. So their head and their chest are actually the same size for a little bit of time. So that's my interesting little fact for you guys today. The heart exam is also going to be very similar to how we examine the adult patient as well. So one of the things I do want to point out to you, if we're having a child or an infant sweating a lot or really having a lot of issues with feeding, these are really early signs of congestive heart failure or congenital heart failure. So this is where we might want to ask some of those other additional questions that I presented to you and dig a little deeper in that patient's history. With inspection of the heart, what we're going to see as far as the point of maximal impulse is at the fourth intercostal space until about age 7. After 7, then it goes to about the 5th left intercostal space at that time. This is where the apical impulse is located, which is where you can actually palpate the heartbeat at this point. You shouldn't see it, but you should be able to palpate it at this point. With that, you can palpate there using the ball of your hand. We can also check for peripheral pulses and different things to, again, assess cardiovascular health. I don't often put in percussion of the borders of the heart with kids, but that could be another examination procedure that you do. And then for sure, we're going to auscultate the heart during our exam. Make sure that your stethoscope is nice and warm, that it's not too cold when we're putting it on the child. You may have to demonstrate on your bear or on yourself how you're going to do this just to get the child comfortable. Sometimes pulling out some of your doctor's equipment can be frightening to kids, so just playing with it, getting them exposed to it, examining and evaluating that equipment can help kind of calm their fears with what you're going to do. We're going to follow the same auscultation pattern as we do in adults. So an easy mnemonic would be APET monkey, if you haven't heard of that. It stands for aortic, pulmonic, Erb's point, tricuspid, and mitral. It just kind of helps you go through the order and how you're going to listen with that. Understand that the heart sounds are going to be a lot louder in kids just because they have thinner chests and it's a lot easier to hear. We've got our S1 and S2 normal sounds. If they've got an S3, that is an extra sound usually heard after the S1 and 2. So it's going to have like a sloshing in sound. This can be a normal finding in young kids or athletes. Sometimes you might hear it in pregnancy. So maybe not an uncommon thing to see in a child patient. The S4 is always pathological. So this is the extra sound that's found before the S1 and 2. So if you've got any abnormalities on your cardiovascular exam, I would highly recommend that you send them out to their pediatrician and they can determine if they need to go on and see a cardiologist at that point. Other things that you might come across are a murmur. So, determining whether or not it's an innocent murmur, which, a lot of kids have these. This is going to require some follow-up questions on your part. Has the parent been told about this murmur? Do they know it's there? What's been the evaluation of the child? Is it something that the pediatrician is just kind of monitoring right now? that would be an innocent type murmur. So this is when, we've got a little bit of regurgitation through the valves. There it's kind of got a whooshing sound going through there, but a lot of times these innocent ones will resolve on their own. An abnormal murmur, you're probably going to see some signs and symptoms and things to go with. So it may be a sign of that cardiovascular congenital anomaly, or something else that might be going on. So the child may have a shortness of breath, again, feeding difficulties, cough. They might have some issues with blood flow, so they might be a little blue, sweating, fainting. Those might also be some signs that maybe something else is going on with this abnormal murmur. You all have access to this link in your notes, but you've probably seen this in physical exam class, that they've given you this website. It's an auscultation assistant, so it's supposed to help you go through the different heart sounds and things you might hear. I would recommend that before, if you haven't had a lot of experience with listening to hearts and different things, that you go and listen to these so you'll be able to hear what the different abnormalities might sound like in the heart. The next area we're going to evaluate is the abdomen. This is where our order of examination is going to change a little bit. So we're still going to inspect first. So when we inspect, we're going to look at the belly. We're going to make sure that it's not too distended, that it's nice and supple, relaxed. We're going to make sure there's no discoloration, scars, rashes, anything like that that might be on the abdomen. We're going to also, in our newborns, look at the umbilicus. So in our newborn babies, and I've got a picture coming up for you, we might see some healing happening with the umbilical cord where it was cut off at birth. So, in the first couple weeks, it's going to have like a dark black scab that forms. After about a month, you're going to start to see that new skin form over the umbilical area. So the main thing we're going to do is inspect the area for signs of infection. We want to make sure that it's not oozing or has discharge coming from it or looks painful or red. We want to make sure that we're looking at that. But, as far as dealing with that, make sure that the parent's not covering up with a Band-Aid or really do anything with it. The main thing is just keeping it dry and not irritated with diaper or anything like that. So it often just pops off on its own and no big deal. When we're looking at the shape and the contour of the stomach, it's not uncommon to see a child, have kind of that pot belly appearance. One of the things that I do want to make sure that you do look at, if their belly is sticking out, that's one thing, but if the belly is protruding above the level of the chest, that is abnormal. That could be a sign that maybe they've got constipation issues. Sometimes just backup of feces can cause that. Could be a mass or just some kind of organ enlargement. So make sure that if the belly is protruding, that it's not protruding above the chest level. I wanted you guys to see a picture of what the umbilical cord healing looks like in a newborn. So in case you do come across this, it doesn't freak you out. But you can just kind of see how it goes through stages, just like a regular wound would have. So you're going to have this black scab that's stump kind of thing that's hanging onto the belly button area. Again, it just kind of falls off on its own. And then by about a month, you should see some nice new skin healing over that area. After we inspect, we're going to auscultate the abdomen. So the auscultation has to be done before the palpation or percussion, so it doesn't alter the frequency or the quality of our bowel sounds that we're going to listen to. Main thing is we're going to listen to the bowel sounds in each of the 4 quadrants. You want to hear about 5 to 34 per minute. A lot of times you're just going to hear some gurgling. Kids get pretty cracked up about, listening to gurgles and, oh, I can hear what you had for breakfast this morning. Whatever you need to do to kind of lighten the mood with them. So make sure that you're listening for that. Also, as far as auscultation, we're also going to listen to the vessels of the abdomen as well. So you're still going to go through listening to the aorta, the renal, iliac, and femoral arteries in that area as well. Before you begin percussing and palpating the abdomen, I would recommend that you make sure the child doesn't need to go to the bathroom first. You don't want to end up having an issue with that as you're working on the abdomen. So make sure that they've gone to the bathroom recently or they don't need to go before you start doing this. You're going to percuss the pediatric abdomen just the same as you would an adult. So you're still going to check for sounds with the percussion. You're also going to feel and percuss the borders of the organs just to make sure that they're normal with that. It's not uncommon to percuss the liver border below the costal margin on the right side. So normal, you might feel it about 1 to 2 centimeters below. Newborn, you might feel it about 3 centimeters below, so that's not uncommon, but anything over that 2 centimeters is abnormal. So we want to take that in consideration. So you may percuss and actually palpate the bottom border of that liver in small kids. You'll also want to percuss the spleen as well as you're doing that. So don't just do a percussion one time in each quadrant just to hear the sound. You're listening for the sounds, yes, but you're also percussing for organ size as well. I've already discussed about the distended abdomen and what causes may come with that, and we've discussed the percussion of the liver and the spleen and different things, but I do want to talk a little bit about palpation. The main thing is if they are coming in with some pain or tenderness that you palpate that area last and then work your way to that. So you don't have to start in the upper left quadrant, work your way around. I would start away from whatever area the child is complaining of hurting, if they do have pain. With palpation, I always start real light and then go deep palpation with that. You're feeling for, any kind of masses, any pain, tenderness with the abdomen at that point. Most commonly what you might feel, and it's going to feel kind of disgusting, but fecal matter is not an uncommon thing for you to palpate during this examination, especially if you're dealing with a kid that maybe has constant or chronic constipation. You may actually feel some like round balls that are like freely movable or sausage-like along that descending colon in the lower left quadrant. So don't be alarmed if you feel that. And if you do, you might want to ask, hey, when was the last bowel movement? The parent may not know, the child may not know, and that may solidify your findings with that. Okay, maybe it's been a while since they've had a bowel movement. So don't be freaked out if that's what you feel. Again, that's going to require some additional questioning at that point. That area, if they are constipated, may be tender. So just keep that in mind as you move through that. But make sure they go to the bathroom before you start percussing and palpating. And then just remember that most commonly what you're going to palpate in that lower left is actually going to be fecal matter. I want you to be aware of some additional abdominal tests. The first two, Danforth sign and Kerr sign, aren't real common ones that you're going to have to worry a lot about in practice, but I do want you to be aware of what they are. So Danforth sign is usually a sign of some kind of liver injury. So when you're palpating the right upper quadrant during your abdominal exam, they're actually going to have some referral pain to their right shoulder. And then opposite of that would be Kerr sign. So when you're palpating the upper left quadrant, they're going to have referral pain into the left shoulder, and that's usually indicating some kind of spleen injury. So those are just some signs I want you to be aware of, just as far as terminology goes, but they're not real common to see in the chiropractic pediatric population. Revosing signs and Bernie's point, I do want you to know these. Appendicitis is a common condition that kids do have, and I want you to be able to identify that. So revosing sign is an indication of appendicitis. So this is when you're palpating in the right lower quadrant and they're actually getting referral pain over into the left lower quadrant. You can also look at rebound tenderness here. You guys have learned this in your physical exam classes, but this is when you're palpating, and as you release the pressure off their abdomen, they get an increase in pain. That's another sign that there's possible appendicitis. And then McBurney's point is another kind of big clue that you've got an appendicitis going on. And it's what this point is, it's located 2/3 of the way from the umbilicus to the ASIS. and it's in the right lower quadrant. And what you're going to have is you're going to have pinpoint tenderness right at that site. So, if a patient coughs and they've got pain right there, oftentimes that's a good sign that they've got appendicitis too. Other signs and symptoms with appendicitis is they'll have, they may even have just some dull pain around their belly button. They're going to have that sharp pain in that lower right quadrant, especially over that McBurney's point. Coughing's going to be hard. They're not going to be able to pass gas, which I think is an interesting symptom. They're not going to want to eat much. They might vomit, be real nauseous. Those are going to be some signs. And also fever is going to be common with this. So if you've got those signs and symptoms presenting and you run through a couple of these signs and abdominal tests, this needs to be an immediate referral if they haven't already gone to urgent care or their pediatrician at that point. They need to be referred out for proper care if you suspect that. I do want to chat a little bit about rectum and genitalia on your examination. As far as our job as a chiropractor, typically we're not going to be evaluating much with the rectum. There might be some concerns that a parent has, so possibility you might observe the area, if baby's coming in with a diaper rash, or sometimes like kids with food allergies and different things will develop like a red ring around their anus. Sometimes parents will want you to check that out to see if that is a concern. If you suspect child abuse, the buttocks, genitalia are common areas where child abuse can happen. So you may want to just inspect the area to make sure there's no injury or trauma there. So those would be some of the more common reasons why you might evaluate the area. But in general, rectum is not going to be a common area on your examination. I do want to chat a little bit about hernias with your pediatric patients. One of the more common ones you're going to see in an infant would be a possibility of an umbilical hernia. This is just going to be a bulge located just above the umbilicus. It may extend up a little bit into the abdomen. It's fairly common in babies. You'll notice it really bulge when they cry or cough or strain. A lot of times these will close by the time the child's 1 or 2 years of age. Often what will happen is a pediatrician will just observe these, especially if they're not symptomatic, they're not causing any pain. They'll just kind of observe the area. And so you'll want to do the same kind of thing on your evaluation. So you'll just note that they do have an umbilical hernia. Again, follow-up questions with this might be, has your pediatrician noticed this? Do you notice any pain or discomfort or redness around the area? We would want to make sure that we evaluate and follow up questions there. But most of the time, these umbilical hernias are just kind of an observation. They go away on their own. Some emergency referrals with these would be, if the bulge looks swollen or it's discolored at any rate, baby looks in pain, if that area is really painful to touch or they're starting to vomit, those would be some signs and symptoms that we'd want to refer out immediately for that baby. If the umbilical hernia doesn't usually resolve by the age of 4, some docs will then go on to do a surgical repair of the area. Another hernia you might come across in the pediatric population is what they call a diaphragmatic hernia. This is often a birth defect, and what will happen is the abdominal organs will push into the chest cavity. This is life-threatening, and they will have to have surgery to repair this. It often impairs respiratory function, and it does have a high mortality rate. So it's got a mortality rate of about 40 to 62%. So it is a very life-threatening situation, and most of the time that's caught at birth and caused by a birth defect. The inguinal hernia check may be part of pre-participation physicals, so you want to make sure that you look at your state sport physical form to see if that is a requirement of that. I've added a snapshot of the physical exam for you guys in Kansas. Right now, it's one of those things that if there's any kind of history or anything that needs to be looked at, then you should proceed with that. But you need to be asking questions about, do you have any pain or bulging in that area? If they've had prior hernias in the past, I would recommend that you do a check on that if you are doing pre-participation physicals, but usually not recommended unless there is a history of some kind of problem in the area. I'll give you an example. So my husband and I are chiropractors, and we often do a group sports physical for one of the high school football teams every spring. And so it's kind of an open bay situation. And so as we go through the history and we ask questions about that area, if they've ever answered yes or had any concerns or maybe even had a hernia repair, then we go ahead and take them into a private setting to perform the inguinal hernia check. I have provided a video in your notes for you to review so you can see what that hernia check looks like in case you need a refresher on that. This is just a picture of the pre-participation physical for Kansas. I will provide you the form in your modules under course resources and stuff, just so you guys can see what this looks like. But it has out to the side that it says, consider the GU exam if in a private setting. So again, you're asking questions, you're evaluating to make sure that this patient is good. Genitalia is not a common area for doctors of chiropractic to look at or evaluate. Once in a while, you may need to inspect the area if a parent has a concern of maybe a yeast infection. Again, sexual abuse, I already mentioned that with the rectum. You may need to take a peek at that. Sometimes in our male infants, we look to make sure that the testes have descended properly. And so most of the time with those is just a quick inspection. There's no palpation, there's no internal exam. Anytime you are examining and observing the genitalia, you want to make sure that there is someone else in your room just to make sure to protect you at that. I also mentioned the Tanner staging earlier as a measurement for sexual maturation. Again, not a common thing for chiropractors to do, but I do want you to be aware of what that is in case you do come across that.